Hello, everyone, and welcome to a WEDI Spotlight on State Medicaid Strategies for CMS-0057-F Implementation. It's my pleasure to introduce Robert Tennant, WEDI's Executive Director.
Thank you, Michael, and it's a pleasure to see all of you today. We have a very exciting program ahead of us. I wanted to start with discussing a little about our organization. There are maybe folks on here that aren't overly familiar with WEDI. So I'll say that we were formed back in 1991 under the first Bush administration. Uh, uh, George H.W. Bush nominated a practicing physician as Secretary of HHS, Dr. Lewis Sullivan, and he knew firsthand some of the challenges that plans and providers face in exchanging health data. So he commissioned what he called the Working Group for Electronic Data Interchange, and they produced two reports in the early 90s, which were converted into legislative language, which became known as HIPAA, which I'm sure you're all familiar with. So we have served in the capacity of advisor to HHS ever since. WEDI was named in HIPAA as an advisor to HHS. And we've got very strong, productive working relationships with many of the federal agencies, including CMS, who you'll hear from later today. In fact, both CMS and ASTP ONC serve on the WEDI Board of Directors. We are a multi-stakeholder organization. We represent health plans, providers, vendors, standards development organizations, state and federal government, and patient advocacy organizations. So we do a lot of our work through our work groups, sub-work groups, and task group, and I'll talk a little about those a little bit later. Basically, our role is simple. Our role is to bring the industry together to identify challenges related to data exchange and health IT, to collaborate, to educate as we're doing today, and influence the direction of the future of data exchange. Next slide. As I mentioned, we do the bulk of our work through our work groups. And you can see here we have work groups in many areas that I'm sure impact your organizations. Most of the HIPAA transactions, including things like claims and remittance and eligibility. But we also have one specific to the dental community. We've got one on property and casualty, genomics, privacy, and security. And our latest one, we just started in September earlier this month, is the patient experience work group. So definitely look to our work group community homepage to learn more about each of these groups and how to get involved. I wanted to spotlight in particular our prior authorization sub work group. That group studies the workflows and business processes related to PA, both from the provider and health plan perspective. I'm really pleased we have a wonderful set of co-chairs for that sub work group, including Janice Bakos from CVS Aetna, Raj Gadafarthi, who you'll hear from later from MCG Health. Michael Lunzer, again, you'll hear from him. He's with Itility Health. And Heather McComas from the American Medical Association. So I wanted to talk about membership because what makes WEDI unique is the fact that if an organization joins WEDI, every employee of that organization is considered a member of WEDI. So if you have an expert in privacy and security, then they would want to attend our work group. If you have somebody involved in claims or remittance or genomics or property and casualty, there's a home for them as well. There's no cap on the number of employees that can join and be part of our work groups. And very importantly, related to our program today, federal government and state entities do not incur any dues for being part of WEDI. So there's no cost at all. You are encouraged strongly to get involved in our work and share your experiences and perspectives. Just to give you a sense, we have a lot of states that are currently signed up as members of WEDI. We've got a few that are not, and I would encourage those that are on today's program that are from these few states, sign up. Again, there's no cost. There's no requirements. All we ask is that you try to attend some of our work groups and share your experiences. I guarantee you that if you have an issue, whether it is data exchange or privacy and security or value-based care, other folks have similar issues, and you will, I think, help the community by sharing your experiences. And again, we've got a number of folks that are members of WEDI but are not active in our work group. So I would strongly encourage you to look over our work group, see the ones that are most interesting to you, and get you and your colleagues signed up to receive the invitations. So again, what makes WEDI unique is our multi-stakeholder membership. It gives you an opportunity to interact directly with your peers from state and federal government, from the payer and provider communities. You're able to ask detailed technical questions of experts that are directly involved with the standards development organizations like X12 or HL7. But also you can hear from vendors. What are some of the solutions that these very creative vendors are developing to help solve some of your problems? Again, it's an opportunity for you to raise issues within a group of peers to try to come up with solutions or find out what other organizations have done to solve their problems. And of course, it's a chance to influence industry direction on policies. We have a very robust advocacy wing in the sense that when a rule comes out or request for information, we're able to pull our membership together and come up with a collective response, a consensus-based response, which I hope is valued by the folks at the federal level. So just to talk a little about what we're planning for today, we are absolutely delighted to be joined by two of our colleagues from the Centers for Medicare and Medicaid Services, David Koppel and Scott Weinberg. They will give an overview of the CMS 0057-F final rule and be able to answer any of your questions. We are delighted as well to have this program because we're able to bring it to you with no charge through the sponsorship of Itility Health. And the Chief Executive Officer, Michael Lunzer, will give a technical overview with his colleague, Keith Brick. And I can tell you that Itility has some tremendous solutions that you may find of great value as you are going through implementation with your own organization. We'll then switch gears and hear from states directly. We'll hear from Malathi Subiaya from the state of Utah, Craig Beam from Maryland, and Joanne Colson from Washington State. We'll then come back together. I'll lead a discussion of next steps and talk about some potential resources that WEDI is developing. And I'll be joined by really three of the national experts on this final rule. Mark Scrimshire from Onyx Health, Raj again, who is co-chair of our prior authorization sub work group, and he's from MCG Health. And then Michael Lunzer, again, one of the co-chairs for our sub work group and head of Itility Health. And with that, go to the next slide. We encourage you to get involved with the discussion. This is an absolutely unique opportunity to have some of the national experts on this final rule available to you. So take full advantage. Use the chat feature to make your comments, to ask questions, to post resources that you know have been effective. Certainly, again, take full advantage of this opportunity. And for your colleagues that may not have been able to join us live, we will send you the slides and the recording, so you'll be able to distribute it within your organization. And with that, it is my pleasure to turn the mic over to David and Scott. Thanks so much for joining us today.
Great, thank you. Yeah, so I'll start us off. Let me just grab the screen here. Okay. Great. Well, all right. Well, thank you. Thank you, everybody, and thank you, WEDI, again for having us come to speak. So we'll, before the rest of the speakers, we'll give you the, the federal overview of 0057-F. We call it the CMS interoperability and prior authorization final rule, or you might hear it referred to as the CMS prior authorization rule. It's all the same thing, and so. So we'll just here to give you this overview here. If you're not familiar, I see a lot of names I recognize, but a lot I don't. The final rule places new provisions to build 3 new APIs, expand the data from an existing API that is already in effect. Some non-technical some non-technical prior authorization processes improvements, and then a new measure for the MIPS and promoting interoperability programs. And so you as an audience, you're Medicaid directors, but so you know that you are an impacted payer under this rule, and we see our complete list of impacted payers here: Medicare Advantage organizations, state Medicaid and CHIP agencies, Medicaid managed care and CHIP managed care entities, and then the qualified health plan issuers on the federally facilitated exchanges. I will keep referring to these as QHP issuers on the FFEs. I'll just to say that up front here. There are a few providers who are directly impacted by this rule, meaning that they will have requirements on them. Those providers are those who report under the Medicare Promoting Interoperability Program or the MIPS program. We're not going to touch on those requirements as much, but if you are interested in learning more about those, you can feel free to go to our website. Okay. So this this graphic here is a relatively new one that we've been using, but it's a kind of a 10,000 level view of what the API's application program interfaces do. So we at CMS are leveraging the data that the payers have, and then those APIs enabling access. So the patient access API, which is already in place, the patient allowed to getting their own data directly from their payer. The provider access API, largely the same data, which I'll be talking about, and then the payer to payer is you see is kind of a bidirectional API. So that means the data will flow both ways, and then the prior authorization API, which will do that as well. So first, if you're not familiar, so the patient access API, this was first finalized in the May 2020 CMS interoperability and patient access final rule, and this expands on the already established API to include information about prior authorization requests and decisions, and then this new data will be going into effect in January 1, 2027, coming up. What's coming up even sooner is the other requirement finalized in this rule, which is API use metrics. So payers will have to report metrics about patient use of the API to CMS on an annual basis. So these metrics include the total number of unique patients whose data are transferred via this API to a patient's health app, as well as the total number of unique patients whose data are transferred more than once via the API to a patient's health app. So you're probably familiar with this, but a good reminder. Now, the next three APIs, which I'll be briefly discussing here, these were brand new from this final rule, and so we're requiring that these should be built and maintained by January 1st, 2027. So the provider access API is an API to allow provider access to patient information. Now, the data is almost the same as the data that's already required to be transferred via the patient access API. I would have to make available individual claims and encounter data, but not including cost sharing information like in the patient access API, data classes and elements in a content standard developed by ASTP ONC that is currently the US CDI or the US core data for interoperability. And then as well as specified prior authorization information for items and services. This does not include drugs. Now, in order to make sure that the data is going to the correct provider who requests it, the effective payers have to develop an attribution process to associate patients with their providers. And these are providers with whom the patient already has a treatment relationship. I'll note we were not prescriptive in how this attribution process should on what this should look like. Impacted payers are free to use ones they already have, but there does need to be an attribution process. And then finally, there does need to impacted payers do need to develop an opt-out process. So they're required to maintain a process for patients to opt out of having their information shared via this API if a provider requests it. And so there would have to be so by default the data would be shared, but the patients will have to get the opportunity to opt out of that data sharing. So the next API, which finalized on this rule, again, beginning January 1st, 2027, is a payer-to-payer API. This is an API to enable data sharing between a patient's old and their new payer, as well as if a patient has two or more concurrent payers. So they would need to share largely the same data that's required to be shared via the other APIs. However, a patient would need to though opt into this data sharing, and so there's various reasons for we can go into why, but why it's an opt-in policy versus an opt-out for the provider access API, but that is the basic requirement for the payer-to-payer API. It could be a little bit confusing. So there are additional requirements related to both these APIs to provide patient and provider educational resources. So with regard to the provider access API, impacted payers will have to provide plain language resources to both their patients about the benefits of API data exchange with their providers, as well as basic information about opting out. So and then also related both to the provider access API is providing information to providers about the process for requesting patient data, about how that will all work through their EHR, as well as your attribution process. So just so providers know, what patients are considered theirs. Similarly, with the payer-to-payer API, impact payers are required to provide a plain language materials about the benefits of payer-to-payer API data exchange, but consistent with the policy is just information about their ability to opt in or withdraw a previous decision to opt into data exchange. We do on our website have information, basic best practices for developing these resources. So I encourage you to go take a look there. And then finally, the last API, the prior authorization API, and this is less about data access and more about making basic prior authorization prior authorization requirements available to the provider directly through their EHR. So this API would have to be populated with a list of items and services, again excluding drugs, that require prior authorization from the payer. It would also have to include documentation requirements for items and services, so to allow a provider to look up what is required for a prior authorization. And finally, and I think more importantly, is it has to enable an electronic prior authorization itself within AHR, this API. And so we know this is in the process of being implemented, but for those not familiar, this is kind of our step towards electronic prior authorization. I mentioned at the top that there is also a MIPS and promoting an interoperability measure. Don't have a slide on it, but really to encourage providers to then use the API through their EHR once this requirement is in place. So these next couple slides, just noting the required standards under this final rule. You should have access to these slides. This is also available on our website, but just showing by API what standards are required under this rule. Not required, but strongly, we'll stress that again, strongly recommended are these FHIR implementation guides by API. If you've seen this chart before, just note that we have updated this with the latest version of some of these IGs, Karen, I think PDEX, CRD. Just know that updated versions did become available in the since we last since we finalized this rule, and just noting that those are acceptable to use. So I think now I will turn things over to my colleague David. He'll talk about improving prior authorization processes, metrics reporting, etc.
Thanks, Scott. Hi, everybody. So in addition to our technology policies, we also have, okay, good. Sorry. I was seeing the transcript when Scott was speaking and I couldn't figure out how to turn it off. And I was really worried that I was going to see it when I was speaking and just be super distracted, but it turned itself off. So pulling back the curtain, I guess. Anyway, so we also have policies that deal with the prior authorization process writ large. And I think the important thing to recognize here is that this is not tied to the prior authorization API. We do expect now I'm getting a too quiet message. We do expect that the prior authorization API will facilitate a lot of these policies. But these policies do apply regardless of how the prior authorization is sent to the payer and how it is received. So the number one thing is establishing timeframes for the prior authorization of items and services. And we we made policies that the impacted payers must make decisions on standard requests within 7 calendar days. Some payers had policies that were longer than that. Some payers did not have time frame requirements at all. And so this is, one of the big things that leads to delays in care, and or patients just abandoning care if they don't get a timely response. And so we wanted to make sure to put requirements around the time frame for making decisions. So for standard requests, that's 7 days, and for expedited requests, that is 72 hours. In addition, we heard from a lot of providers that while there were requirements to send notices to patients to make sure that they saw the outcome of a prior authorization, there were not necessarily requirements to send that same decision to providers. And most importantly, when a request was denied, that providers were not seeing a specific reason for denial, and that was oftentimes they had to wait and for that notice to go to patients. Often that notice is mailed. And so there was just this long timeline between submitting the request, getting a decision, having that decision sent to the patient then having to go back and share that information with their provider in order to address the reason that the request was denied, whether that was to submit more information, appeal, or just say, okay, well, this is denied, let's look at alternative treatments. So we require impacted payers now to respond directly to providers when they deny a request with a specific reason for denial. And then finally, we require impacted payers to publicly report certain metrics. It is currently difficult to understand what the landscape of prior authorization looks like. We have some data. The AMA does an annual survey, the AHA does an annual survey, but there's nothing really directly from payers. And so we wanted to ensure that we could see the whole universe of prior authorization, understand how it's being used around the nation, and be able to compare types of payers against each other, individual payers against each other, and to allow the public to do that as well. Patients may use that when selecting a plan. Providers may use it when determining which networks they want to be a part of. And so we have required that payers publicly report metrics on their own websites for the public to see, including us at CMS as the regulator, and ensuring that that payers are compliant with the requirements. I'll just highlight that the first year that those are required is 2026, whereas these other requirements go into effect in 2026. So thank you. So for the first set of data that payers are required to report is 2025. So that's really going to be a baseline before any of the requirements in this rule go into effect. So we're gonna get that 2025 data in 2026, and then in 2027 we'll get 2026 data that will hopefully show changes based on the requirements in this rule. Here's a list of those metrics. I'm not going to read them to you, but you can see, number approved, denied, appeal, and mean and median time that takes place between the request and the decision. Next slide. Oh, so we have published a sample prior authorization metrics template, not required to be used, but we got a lot of feedback that payers want to see what a good or an acceptable format would be. And so we have put out a sample that we think breaks these metrics down in a pretty clear way. And also include some other optional recommendations that we make. So for instance, some of the metrics are percentages. And we think that it could be very helpful to also actually publish the numerators and denominators, because it will give a sense of the scope, whether this is a huge number of prior authorizations that are being represented or a very small number. Because that would, that could change somebody's interpretation of the percentage. So that is on our website. We also have an example of presenting it visually, as you can see by this donut chart, that we think will help patients, providers, members of the public understand how each of these metrics relate to each other, and just make it kind of visually appealing, because that's we think what sticks in people's minds often. In addition, we have released similar metrics from Medicare fee-for-service that can also be used as an example. They aren't exactly the same, but it's really to give an idea. This is not a required template. We're not going to make this required. At least at this point, I guess. I can't speak to what may or may not happen in the future, but these are really just to give a sample of how we recommend payers display this information. Next slide. So this is just a list of compliance dates. As I said, these proposals. I keep wanting to say proposals. Policies go into effect in January 2026 because we thought those were really urgent and those could be addressed, needed to be addressed before, not necessarily before the technology, but we heard that payers and developers needed more time to develop the technology than they necessarily did to implement some of these workflow changes. And so that is why we finalized 2026 deadlines for these process improvements, and then 2027 deadlines for the technology piece, just based on the comments that we got back. Next slide. Is there another slide? Yeah, so then I also want to emphasize that we have a proposed rule under development that is public in the unified agenda. And that is, this rule is primarily to incorporate drugs into our policies. So in the last rule, we only regulated non-drug items and services. And we got a lot of comments back, a lot of feedback that prior authorization for drugs is also a big issue that we need to address. And so we are working on a proposed rule that will focus on drugs and apply, without saying anything I shouldn't, applying a lot of the policies in this rule to also cover drugs, just to make sure that, there's equity between those two types of items and services, essentially. Next slide. So yeah, we just, happy to share these slides if we haven't already, but links to our website and where you can find more information. So I don't know if we have time for questions. I apologize. Rob, let me know. But if we don't have time, always feel free to shoot us an email at cmsinteroperability@cms.hhs.gov, and we will get back to you.
Yeah, we do have some time for questions. If you have questions for David or Scott, this is again a wonderful opportunity to hear directly from CMS. If you've got questions, either put them in the chat or raise your hand, and we can take you off of mute if you'd like to ask the question directly.
So, and I'm happy to address Lisa's question here in the chat, which is, are we considering drugs covered under medical benefits differently from retail drugs covered under a PBM? The answer is absolutely yes. We understand that there are different standards depending on how those drugs are covered. The current or the existing standard for retail drugs is the NCPDP script standard that is adopted under the HIPAA administrative simplification rules. Medicare Advantage put out a rule last year, I want to say, that requires Part D sponsors to use NCPDP script for electronic prescribing. One segment of that standard is electronic prior authorization. So yes, we are aware that there are different standards for different types of drugs depending on how they are covered, and we are accounting for that. Is dental considered part of the prior authorization? So, well, first timeline. I can't give a timeline. That is just a universal thing that we don't do. Not particular to this rule or particular to where we are in the process, but we are trying to get it out as quickly as possible. Is dental considered part of the prior authorization rule? Yes. Yes, it is. There is nothing that carves dental services, items or services out from all of the requirements of this rule. So they are covered. That said, we do know that dental providers have different needs and have different there are some different standards. There are also different EHRs, and the EHRs are built to some different functionalities based on dental needs and workflow. So we are looking into that and trying to see what we can do to help dentists and other dental providers. But at this point, they are wrapped into, or they are part of the medical items and services, because dental care is healthcare. And so the same requirements do apply, or will apply when on the effective date or compliance date. I don't know if other people have come off mute or on video to ask questions. So.
Hi, David. We have a couple of more questions here after the dental. Are the public metrics for prior authorization for Medicaid, Medi-Cal data only?
So I assume this is being asked in the California context. I guess I'm not sure exactly what other data you'd be asking, but the Medicaid agency is only responsible for reporting their fee-for-service beneficiaries because they are the state Medicaid agency, and the same is true as CHIP. the state Medicaid agency is responsible for coverage of those patients and therefore for prior authorization. The state Medicaid agency is not responsible for reporting the metrics of their managed care plans. The managed care plans themselves are impacted payers and are responsible for that. However, I would recommend that, it would benefit your beneficiaries to aggregate that data and have it in a central place. So if states want to require their managed care plans to also report that information directly to them, nothing that prohibits that, certainly. And that would allow a state Medicaid agency to post those metrics on their own website and say, here are the 10 plans that we contract with, and here are their prior authorization metrics in one centralized location so that people don't have to go to each plan's website individually. But again, that is optional. That would be up to the state and the state policy. As far as our rule goes, managed care plans are responsible for their own data. And I hope that answers the question.
Thank you. One last question in the chat right now from Mark, just confirming reporting on patient access API usage is beginning in 2026 by March 31st.
So the usage metrics, is that right, Scott? Sorry, I don't off the top of my head.
Yeah, here I'll pull up the yes. Report.
Yes. Yeah, that's the top one. Right. So yes, patient access usage metrics are due in 2026, and that is because the API itself had an implementation date, compliance date in 2021. I don't know, Scott.
We put January 1st, 2026 here. I think because that's when it's, I guess, effective, but is it? Right.
Yeah, right. Right. So the deadline is actually March 31st, right?
Yeah.
But it's the policy is effective.
Yeah. Apologies to the question asker who I think we're being a little too wonky here. Yeah. So by March 31st, report by March 31st. Right. Yeah.
Excellent. And I'm going to allow Jeanette Gonzalez, I'm going to unmute you so you can follow up with your question.
Oh, hi. Thank you again. So I am in California, and we do have managed care plans who do have a commercial side to them. So I was curious if the public metrics on their website should be specific to Medi-Cal data only.
Oh, okay. So I see. So that you have a plan through Blue Cross Blue Shield, and the question is whether Blue Cross Blue Shield would be reporting only their California, their Medicaid managed care plan. And the answer is yes. Okay. Yes, they need to report it by line of business, as we define that within the impacted payers, as we define impacted payers. So yes, their Medicaid managed care plan would only be their Medicaid managed care plan. If they also offer, say, Medicare Advantage, sorry, I don't know. My words might be getting jumbled up. Their Medicaid managed care plan, if they also offer Medicare Advantage, they would be required to report that separately. And then we don't have any requirements on commercial plans that are not impacted payers, because those are the payers we have authority to regulate. But I also see Mark put in a note about a California law that may require similar reporting for all commercial plans.
Thank you.
Okay. Excellent. David, Scott, fantastic. Thank you very much for sticking around. If there are any questions, if you can stick around and check out the chat, there may be some more questions you might be able to address. But thank you once again for a very informative presentation.
Sure, anytime. And if there are questions, again, please feel free to reach out to that mailbox and we'll get back to you.
Excellent. And Scott and David's slides will be sent out to all registrants post-event. It's my pleasure to introduce Michael Lunzer, Chief Executive Officer with Itility Health, and Keith Brick, Interoperability Architect, also with Itility Health, for our technical overview of CMS-0057.
Good afternoon. Thank you very much for the introduction. We're excited to talk with you today about CMS-0057-F and really focusing in on a technical overview for the prior authorization API components of 0057-F. My name is Michael Lunzer. I'm the CEO and founder of Itility Health. I actually came from inside of Blue Cross Blue Shield of Minnesota a number of years ago, and Itility Health was founded inside that environment, really focusing in on understanding the needs of payers and how we can improve the relationship between payers and providers. With me here today is Keith Brick. I'll let him introduce himself as well. Keith?
Thank you, Michael. Reporting live from the heart of the Epic Deep Space Auditorium. I'm here at the Epic Developer Conference, helping not only Epic, but all of the organizations that use Epic understand how TEFCA is going to make this prior authorization workflow easier. And I'm stepping away from that conference to help everybody on this call understand that this technology benefits the providers just as much as it benefits the payers. And it's easy to set up. And with the help of the states, we can make it so that the state programs are standardized, easy to implement, and according to those metrics, it's really important that we are able to turn around fast answers, so that we're going to make it easy to get back a fast answer too. So thank you, Michael.
So to start with, we'd just like to frame up what are the specific questions we're going to answer today. So first of all, what are the technical requirements for compliance of CMS 0057 prior authorizations? What are some of the necessary transformations that will need to take place to meet that requirement? How does this impact state Medicaid organizations? And then what are some of the opportunities from CMS 0057? So first of all, just some very basic information. Of course, prior authorization seems pretty straightforward. A provider needs to know whether or not a prior authorization is required, and then they need to know, what do we need to submit and how do we get this prior authorization approved? And many of those details are very specifically oriented towards the patient's health plan that they have in place. So answering these questions about the patient's specific health plan can be fairly challenging. First of all, is prior auth required? Can be buried in various systems at the health plan or at the state Medicaid organization. What data does the policy need, the medical policy requirements? Within state Medicaid organizations, that information is often buried in provider manuals. And then, is it approved? That's just a mechanism that needs to be in place to allow for an answer to be submitted back to the payer, to the provider. So in terms of CMS 0057 and prior authorization, it provides a great structure that organizes this series of transactions to give payers and providers a good method of communication. So the first of those transactions is what's called the coverage requirements discovery transaction. And that is essentially there to help the provider to know, does it require a prior authorization? The second transaction that's part of 0057 is the documents, templates, and rules transaction, which is essentially intended to help answer the question, what data does the payer's policy need to be sent back in order to get an approval? It can go much deeper than that, and we'll talk more about how questionnaires impact this particular transaction. And then the last transaction that's a part of the API requirements is prior authorization submission, or PAS. And that's the submission of the prior auth electronically and the ability to answer the question, is it approved? And are there additional pieces of information that the payer needs in this case? One of the real big challenges here is that today, many of the document systems that are in place don't meet or can't meet these requirements. So many organizations have spreadsheets or other static documents that providers can refer to answer the question, is prior auth required? Oftentimes, those static documents don't cover many of the various carve-outs or unique cases, and they're very high level. Next, in terms of what policy data is needed, and what data is needed in order to meet that requirement, that information is often buried deep in provider manuals within state Medicaid organizations. Within typical health plans, they oftentimes have medical policies that address these questions, but those often are also buried in a PDF and a data store or a Word document. And those, of course, are not a great way to automate transactions. Lastly, is it approved? In that case, the payer, the Medicaid organization, needs some method to receive that information and hopefully automate some of the answers to those questions. And so again, in order to facilitate these transactions, there are some key elements that payers, Medicaid organizations need to implement in order to facilitate this automation. First of all, there needs to be some method of documenting these rules in a structured database that can take in an electronic request for is a prior auth required and answer that accurately. Similarly, the medical policy information or the provider manual needs to be essentially ingested into a system that carves out and restructures that data into a scenario where when that provider submits this request to say, what do I need to submit? There's the ability for that medical policy system to answer back very specifically in the context of the specific requested transaction. And then, of course, the payer needs some method of receiving that prior authorization submission and answering those questions. When we think about what the technical architecture looks like, this expands that picture a bit, and I'll just walk through it briefly. On the left side, the provider interface to these new prior authorization transactions can be built into their electronic medical record system. And HTI 4, which has recently been finalized, requires those EMR systems to ultimately support these transactions natively. Another option for the provider is to use a Smart on Fire application or some method of application that interfaces to these transactions. In the middle, we have some method of connecting the provider to the payer. As Keith alluded to, TEFCA and the QHIN organizations will be a wonderful way for those connections to be facilitated. There are other methods of connections that are also acceptable. Providers can directly connect to payers, and there can be various proprietary multi-party connection mechanisms, all of which need to be essentially supporting FHIR. The next entity in this diagram is the FHIR server. Many providers and payers have some method of connecting each other via FHIR and utilize an interoperability server to facilitate that function. This is a great way for payers to have a digital front door to their organization. Next up, you have at the top of this diagram on the right, the CRD, or prior auth rules source of truth. Again, that coverage requirements discovery, which is the CRD transaction that comes from the provider, needs some type of system at the payer to be able to automate that answer. Does it require prior authorization? That system also needs to know about any delegated vendors or remote guidelines that might be in place as well. Next up is the DTR, or Documents, Templates, and Rules database. This system needs to be able to respond back to the provider, again, with that medical policy information, specifically a questionnaire, and we'll talk more about that in a minute, that helps the provider to know what to submit, answer various questions, can also automate the answer to those questions inside the EMR to streamline this process. Lastly, is the PAS capability, and there needs to be some mechanism to receive that prior authorization submission and automate the decisions based upon the rules and the questions that were in that documents, templates, and rules questionnaire. Connected to those systems can also be the utilization management system. That's typically more of the case management status kind of information, so that when a prior authorization is submitted, it has a case number. Humans that need to touch those prior authorizations can also interact with those prior auths that are submitted. In some cases, you'll find elements of the things on the right kind of combined together in various vendors' systems. But again, they're all very specialized capabilities. Just a quick nod to how Itility Health fits into this picture. We have a product on the right that you see that's called PA Checkpoint Database. That's essentially that is-auth required database. Policy Management Database, which is where those questionnaires and policies can be generated. And then Auto Authorization and Clinical Assistant. So getting a little more granular, some of the key elements within this coverage requirements discovery, again, this needs to be a transactional system that can respond to that is authorization required request. And the data that's going to come to the payer from the provider includes information about the patient, the ordering provider, performing provider, procedure codes, and also information about the patient's healthcare policy, their health insurance policy, that hopefully that payer can cross-reference to understand very specifically what that patient's specific coverage is in order to answer that question, does it require a prior authorization?
Oh, Michael, this is a great spot to answer Teresa and Kimberly's question about what happens when we need to give a fast answer to is prior auth required, or respond to a submission with a status of approved or denied. What are the other statuses that we can use? Well, during the CRD process, we can say prior authorization is required, it's not required, it might be required under certain conditions, needs information, or it's satisfied. And the satisfied status is really cool. It's one of those statuses that allow us to say, you've submitted all of the information that we need. You've told us the performing location, the performing date. You've given us the procedure code and the patient's diagnoses. Maybe we've used the prior authorization access token to go and pull a specific piece of background information that we needed to approve that prior auth. And now we've done that for you instantaneously. That's the satisfied status that we can use during CRD to indicate that prior authorization has been approved immediately. When we get a little bit further on, we can do a similar thing during the prior authorization submission by responding with the status of pending and indicate what additional information is needed. Back to you, Michael.
Thank you, Keith. And again, we're moving a little fast here because there's a lot of material to cover. But again, happy to answer additional questions offline as well. So in terms of the DTR, the provider sends over a bundle of information similar to the CRD request that says, what exactly do we need to submit? The payer's response back includes one or more questionnaires that are relevant to the procedures that have been requested, as well as, in some cases, codes that can be associated to questions within the questionnaires, which essentially, when received by the EMR, these questionnaires, if they have enough information, including those codes, the EMR can automatically fill in the answer to those questions. Ultimately, that's the long-term vision for how these questionnaires will want to be structured, is in such a way as the EMR will be able to automate the answers to as many questions as possible. There's a transformational process that will take place that will take some time for payers to convert their criteria into questionnaires, and then eventually add value sets to those questionnaires that allow them to be automated. And there's a evolution of EMR systems, which will allow them to fill in all of that information in those codified questions. In that interim period of time, there are definitely some things that will need to evolve. Oops, I hit the wrong button. I knew I was confused by my slides. Sorry. So this is an example of a questionnaire that can be generated from a medical policy and its associated criteria. Again, some of these questions may be able to be automatically answered within the EMR. Some of the questions might have codes that allow that automation. For instance, when there's a document that's needed to be attached, there can be a LOINC code that's associated, so that essentially the goal, of course, is to get it to the point where this questionnaire can be automatically answered on the EMR. An interim step, however, is if these questions are answered by a human that effectively meets the requirements. The goal then, of course, is for that question, that submitted prior authorization, to be able to be answered immediately by the payer in a positive way. The last element is that PAS submission capability. And so when the provider submits their prior authorization submission, they include a number of pieces of information about the patient, as well as all of their questionnaire responses and any associated elements. And from there, the payer can respond back with an answer. Again, as Keith mentioned, approved, pended, or denied. And this allows the provider to get an immediate answer, as well as to be able to continually be updated as this system and process continues at the payer organization. So I'm going to transition now a little bit from what is the CMS requirement for prior authorization APIs to some of the more detailed information about what are some of the opportunities for state Medicaid organizations. So states with non-managed Medicaid should, of course, anticipate the ability to support the full capabilities of the EPA requirements. So CRD, DTR, and PASS. States with managed Medicaid have a tremendous opportunity to improve their state's overall efficiency with prior authorization. What we have found, again, is that state Medicaid organizations have provider manuals, which oftentimes are documents with hundreds of pages that might have a table of contents that's easy to navigate, that gets a person to the specific requirements for a particular category. But again, those documents are not going to be able to support the requirement of that DTR, being able to clearly and quickly identify, if a prior authorization is required, what needs to be submitted, what questions need to be answered in order to get that prior authorization processed quickly. So,
and Michael, again, that's a very hot topic here at the developer conference, is that Epic customers are asking, how can we satisfy those prior authorization requirements if all we have from the state is a PDF? If it's a 200-page PDF provider manual, it's not computable. So what we would love to help you do is digitize your policies and provider manuals so that those requirements are machine readable, and so that the EHR, Epic, and everybody else can provide those documents immediately upon request. You can put it directly into that prior authorization submission and deliver it electronically, so that we can get rid of those faxes, we can get rid of the manual processes that are costing so much money today.
And just a little bit of an aside on that, Itility Health is currently working with Medicaid managed care organizations And many of them are working, some of them, I should say, are working to ingest and convert Medicaid provider manuals and convert them into these medical policy structures. And that's, of course, very inefficient because at the source, you've created these documents, and now the state Medicaid managed care organizations have to go in and one by one convert these documents. And each of the managed Medicaid organizations will also need to do this. So it's a scenario where there's one document from you and many payers are converting those documents at the same time with the same outcome. So is there this great opportunity for you to help them? So one specific thing I wanted to talk about questionnaires, because that's essentially the essence of that DTR transaction. And that's the need to convert the criteria that are buried in that provider manual and the specific policy into an API compliant questionnaire. And again, I showed you a questionnaire example a few minutes ago. That FHIR questionnaire, I think there's been some misperception of what is a FHIR questionnaire. A FHIR questionnaire essentially is a method of requesting provider information. It does not mean everything has to be in the form of a question as a Jeopardy contest question. It can be yes or no questions. It can be text entry questions. It can be clinical measurement questions like what is the patient's BMI? And it can be document attachment requests. And as I mentioned earlier, some of these questions can have codes associated with them that will allow the EHR to automatically answer the questions. Again, we see that as an evolutionary process because it's a big task for the payer or the state Medicaid organization to convert their policies or their criteria questions into scenarios where every question has a code. And then even if the state organizations or the payers convert all of their questionnaires into coded, all questions being coded, the EHR systems will not necessarily be able to answer all of those coded questions as EHR organizations come up to speed on this capability. So this will be an evolutionary process. But how do we get from where we are to at least the first step of that evolution? We mentioned just briefly that Medicaid organizations, state Medicaid organizations create provider manuals. Typically, those manuals are created by a work group writing up a policy or a document in Word. Then there's a process of getting that approved and then somehow merging it together into the provider manual and deploying that on the public website. There's some big challenges with this in terms of tracking versions, effective dates of changes, approvals, maintaining auditability and the ability to go back in time and know what was the policy at a certain point, not to mention the inefficiencies of taking Word documents and giving them to a website deployment team and having to manage those things manually. And then lastly, this type of a process creates a really big challenge for the payer and the provider in finding the policy that applies to a particular code or condition. So there's this great opportunity for states to kind of redesign the process. Itility Health has a tool. I'm sure there are other ways that you can redesign this process. Ultimately, what you need to strive for is a system that allows you to edit and create and edit these policies as discrete entities down to the procedure code that allow a system to quickly retrieve what is the policy and the data questionnaire that refers to a specific procedure code or procedure. So again, what we have here is a scenario where your policy team uses a system that allows them to interact with the policy and the provider manual that then can dynamically create the full provider manual as well as allow providers and payers to find specific sections of the provider manual and have that system support the machine readable requirements for questionnaires that can be quickly sourced based upon the data in the transaction that says what questionnaire is required and have that questionnaire come over in a unified format. So just a couple of screenshots from what that means and looks like within a system. This happens to be a utility health system, and I'm showing Blue Cross Blue Shield of Alabama's experience with this system. So within their public website, if you go to look for a policy, and you can do that search by procedure code, keyword, date effective, etc., it will find the exact policy, and it will show the user what that policy looks like for that specific element. What's happening in the background when it's pulling up that policy is it's actually dynamically assembling this document from the various entities that are a part of that policy. So we have questionnaires and criteria and other content and attachments. All of that, again, is separately distinct data-based elements within a policy management system, and then dynamically assembled to make it look exactly like the policy or the provider manual looks like today, but with tools that make the revisions and the management of this data very efficient for the policy management team. From this initial ingestion of a policy, we ingest policies automatically to create these separate buckets of information. We then give the policy manager the ability to look just at the criteria section of that policy and have it automatically converted from text-oriented procedure criteria into what we call a JSON, or a more codified method, where you see the and the or and the other rules automatically represented, and within the database, they're actually separate and distinct items. So now, from this document, we can immediately create the questionnaire that represents the same criteria in a more questionnaire-oriented fashion, which can be sent over to the electronic medical record system, and then the provider user, sees this questionnaire in a way that allows it to be filled out, allows the EMR to automatically fill it out, and therefore prior authorization is extremely quickly supported. This is just an example of what that code looks like that is sent over to the provider system. And again, this code is automatically generated based upon the ingestion of the health plan or the Medicaid organization's criteria, and then automatically created. By the way, our system does not use AI to do this. It uses very intelligent rules-based capabilities, and that's really important. So I'm just going to close with a couple of key slides and then see if there are have a couple of questions we can answer. Again, just a little bit about utility health. We were started within Blue Cross Blue Shield of Minnesota. Our foundation and focus of our company is codifying rules and policies powering human readable and machine readable interactions. We have 5 years experience digitizing rules and policies for multiple health plans, which has gotten us a lot of credibility from various consulting organizations. We have a suite of products that not only codify these rules, but also can automate the decision making. And then lastly, we have a blue chip suite of customers that have been using our solutions for many years, which is what puts us in a really unique position. These tools that we have can be utilized to power the CMS compliant APIs, but also the legacy web and other systems that payers utilize. So our customers have been using us to power their public website, is-auth required, and policy management capabilities for many years, and now can just turn on that application programming interface for CMS. So with that, I'm going to pause for questions. I know we're right up against time, but if the WEDI organization can kind of give us any thoughts on questions we can answer now, or again, we'd be happy to answer questions offline.
Sure. Thank you, Michael. Thank you, Keith. There is a question in the chat. What is the maintenance effort for states once the provider manuals are converted to a digital machine readable format?
Yeah, that's one of the really exciting concepts that we've created here, is that the maintenance of this is essentially goes back to the point where when you're making a change to a policy, you make that change natively inside of the tool. So you're not having to create policies in Microsoft Word. If you want to export them to Word so you can send them to people, you can, or your creative and approval personnel can log directly into the system. And instead of having to modify an entire policy when a disclaimer changes or there's one particular rule change, they can go in and make just that one rule change, create a new version of that policy, and put a date, an effective date on that policy, and save it. Once that's been approved, it's automatically available through the various transparency mechanisms of the public website or the machine-readable artifacts for the DTR.
Excellent. And the final question we'll take right now before we move on to our next session, what are the reporting capabilities of your policy engine?
Yes, the policy engine is extremely powerful. We track every change, who makes every change. We know the effective date of new policies and changes so that we can easily make it possible for a user to go find the policy that applies to their transaction, whether that's a provider or even a state Medicaid member. To be able to go look at what is the policy that applies, what are the rules that the provider is going to be following in order to get that prior auth approved, and then what do I need to submit in order to perform that. So that transactional interface allows you to report on any of these metrics and makes all of this information transparent to providers, payers, and members to the level that the organization wishes to make that information transparent.
Excellent. Thank you very much. Hopefully you can stick around for a couple of minutes while folks may have questions in the chat. But once again, thank you to Michael Lunzer and Keith Brick with Itility, and thank you to Itility for sponsoring our state Medicaid event today.
Thank you.
Now we're moving on to our next session. We've just heard great foundational information from folks in the know, from the regulation perspective, and from the, I'm trying to pull my camera up here, and from the technical perspective. And now it's time to talk to some healthcare stakeholders who are in the midst of implementation. So I'd like to introduce my three guests for this panel. Allow them to introduce themselves once we get them on camera. Okay, we have Craig Beam from CRISP Shared Services, Malathi Sabia for the state of Utah, and Joellen Colson from the state of Minnesota. Okay, there you are. Fantastic. Welcome. I'm looking forward to having this conversation with you guys. Jumping into the first question, Joellen, it's kind of interesting. You're coming from a unique perspective here, as there are certain elements within 0057 when it comes to the Washington State Legislature, which might be different from everyone else. So give the audience a couple of minutes to talk about the story at Washington State and how it might be different from what everyone else is experiencing.
Yeah, sure thing. Thanks, Michael. Nice to meet everyone. A lot of great learning happening today, so really appreciate everyone's expertise. A little bit about Washington State first. We have almost 2 million Washingtonians on Medicaid, or Apple Health as we call it. Our care is delivered via 5 managed care organizations, and about 15% of our clients are fee-for-service. So we did have state legislation that initially passed in 2023 and a subsequent bill in 2025. So this legislation has allowed us to move into this work. It has also presented some complexity. There are different groups covered, different timelines, etc. Some of the differences, the state legislation requires faster turnaround times for commercial plans, our managed care organizations, and our retiree plans. The state legislation does not cover our fee-for-service clients. and it does include prescription drugs. In addition, it requires an annual policy review. Fortunately, the legislation in 2025 did align some of the dates, particularly with the API, with the federal guidelines. So I'd like to now speak a little bit to the planning process part of your question, Michael, and I'll speak to agency specifics as well as a FHIR work group. Certainly our agency specific planning process is multi-divisional. There are a lot of content experts that need to touch this work, and so we're collaborating across agency to ensure that all those viewpoints and talents and skill sets are captured. We're focusing on 4 areas. One, new technology tools, primarily as API. 2, changes to existing prior authorization business processes, including the faster turnaround time. 3, making prior auth clinical review criteria more transparent, reviewing annually and updating as necessary. And then 4th, supporting and oversight of the MCO implementation and the ongoing compliance that's related to those standards. And so certainly we are conducting a review of existing policy. Just the prior speakers had some great information about digitization that I know other team members are hoping for some strategies and efficiency wins in the future. In addition to our internal agency efforts, we're really fortunate to have funding and support from Gates Ventures to support the formation of a FHIR-enabled prior authorization payer work group. This work group is enhancing interoperability throughout the state and working towards successful implementation of the prior auth API. And this work is in conjunction with our Office of Insurance Commissioner. The OIC already tracks and reports health plan prior authorization data annually to the legislature. So the FHIR work groups launched in January of 25, and they're providing the support and education to Washington payers to reach compliance for both state legislation and federal legislation. The payer work group is operating in parallel to a provider work group that's focusing on education and engagement. We have about 10-ish payers and multiple provider organizations participating in these work groups. And so we're currently in the process of having those work groups receive presentations from our EMR vendors operating in Washington State. And that has been very, very helpful to have those conversations and work through the complexities.
That's fantastic. And there'll be additional information about that Washington State work at our national conference taking place in November. Jim Adamson, who has been working with you, will be involved in that. Craig Beam with CRISP Shared Services. Before we go into the unique position you are at HIE, please offer the audience a little more information about CRISP Shared Services.
Sure, and thank you so much for having me here. I'm maybe a square peg in a round hole, but really appreciate being part of the discussion. So CRISP Shared Services provides infrastructure and interoperability support to a handful of states across the country. Really, our goal is to reuse technology in a way that allows for state-based organizations, most commonly nonprofit health information exchanges, to run their own data use, run their own stakeholder work, do their own collaboration, but leverage kind of a best-in-class platform. And so in that experience, we spend a lot of time both with our direct customers at the HIEs and then their customers at providers and plans and policymakers to really talk through what makes sense from a statewide approach. I think something that we've seen very commonly on the kind of EHR interoperability side is that kind of a solution will work really well for a large health system, or really well for a provider, or a community provider, or really well for an insurance carrier. But then when you kind of say, well, how's it working for everybody? Kind of they're talking past each other, or solutions, wind up driving multiple portals, multiple workflows. And and so I'm not sure it's entirely apples to apples, but I do think there's maybe a little bit of room in this conversation to kind of elevate above individual stakeholders, just like we heard Washington's doing, and to say, like, what is a broader architecture? What's a broader approach that really, drives the outcomes we're looking for, not just compliance with, whatever the mandate might be.
Excellent. Thank you. Malathi, from the state of Utah, welcome. Please offer the audience kind of your current state at the state of Utah in terms of implementation of 0057.
And I'm happy to be a part of this conversation. CMS 9115F with patient access API and provider directory API are both implemented and live today in production. Provider directory metrics are established. Improvements in the prior authorization processes around the decision timelines, denial reason are all in place now. A sandbox environment with a goal that all APIs can avail using the sandbox environment for testing with our providers, payers, and vendor apps is also in place. We are structuring our final rule implementation around a phased delivery aligned to CMS timelines, but also paced for real world adoption. So we are using the sandbox environment where we can test our patient access API and the CRD and DTR today. We are working on enhancing our patient access API to add prior authorization data and publish prior authorization metrics by the end of this year. And early next year, we are exploring a pilot launch for CRD, which will be our first big milestone in this final rule journey. Looking ahead into 2026, we are focused on testing DTR and prior auth APIs with providers and QHINs. We are also working on peer-to-peer and provider access APIs in parallel with a strong focus on getting the consent workflows right. And work is in progress towards member communication, website updates, and publishing our API capability statements to support providers and payers' readiness. It's a lot, and we've got risk registers in place, mitigation strategies mapped out. So, we are balancing compliance with usability, and we are actively engaging with stakeholders early, using every opportunity such as CMS connectathons or through our One Utah Health Collaborative to make sure we are building it right.
Excellent. Oh, wow. Very impressive. Let's go. And by the way, folks, if you have any questions at any time, please enter them in the chat. This is kind of an open discussion. I have questions, of course, but feel free to offer your questions as well. All three of you talked about the power of multi-stakeholders. So what lessons have you learned about collaborating with payers, providers, and vendors to align workflows and meet the requirements of the rule? Let's jump first with Joellen. Your thoughts on lessons learned so far with collaboration. Oh, I think you're on mute.
Can you hear me now?
Yep, I can.
Awesome. As I mentioned, we've been so fortunate to have the work groups. So it certainly helps to have an external partner to help convene those work groups. We're definitely finding that our stakeholders are at different levels of understanding. And so the sooner you can pull folks into the conversation, the better. We also, I think we all know how diverse the healthcare landscape is. You have your small independent practices to the big multinational practices. So, and payers are the same. So I think the earlier, the better for conversations. And then at the state level, an additional stakeholder is our legislature. So ensuring that we're communicating with them, answering their questions, and also realizing that everyone has a different solution or a potential solution to this challenge.
Excellent. Craig.
Yeah, of course, I agree with all that. Maybe for a slightly different angle on it, I think one thing we find often when we work with different stakeholders and talk to different folks is that there's a lot of technology and technology policy that can be built on. We've been hearing all afternoon that there's been, these APIs, these requirements didn't come out of nowhere. They were kind of built on best practices and standards and work groups. Certainly FHIR is something the entire industry is is moving towards as we consider modernizing and streamlining the way data flows. And so I'm hopeful that more and more as different groups start working together and implementing, they'll see that the implementation guide for these specific APIs are not that different from the implementation guides for other APIs, and that some of the technology or maybe even some of the personal relationships actually overlap heavily because clinicians and payers have been working together forever. So you're doing something a little bit different, but I do think there's a lot we can reuse. There's a lot of infrastructure we can build on as we do these next things.
Definitely. Malati, before I go into the two questions, that folks are very impressed with the work that you're doing in Utah, but talk about, the power of collaboration that, has afforded you the ability to move at such a fantastic pace. And then we'll go into the questions in the chat.
Sure. We are fortunate to actually be working with One Utah Digital Health Collaborative. That's an office that works with the governor's office and Utah Department of HHS, and they lead the multi-payer, multi-provider, state-based collaborative efforts to support the final rule. It's been quite a journey for us since joining the One Utah Digital Health Collaborative pilot back in early 2024, and then the CMS Connectathon in July 2024. We definitely learned that interoperability comes down to one thing, which is collaboration, right?
Mm-hmm.
So our first big hurdle was simply getting all the systems talk to each other. So, at our first Connectathon, CMS Connectathon in July 2024, our goal was to just get our sandbox CRD API to successfully connect with a QHEN. And just establishing that basic connectivity, receiving a request and sending a CRD card response back, it was a challenge. And when we got that to work, that was a huge win and a major lesson in how challenging the initial setup could be. And at our next CMS Connectathon, we had issues struggling with, we had difficulty in getting this adaptive questionnaire working. And then we figured out that instead of getting really stuck with this, and which is difficult to implement within this 2027 timeframe, it prompted us to work with our partners to find a more near-term solution with the possibility of going adaptive in the near future. So we went in the route of sharing downloadable documents for this first go live. And that iterative process of working together to solve problems rather than just collaborating, I think that's really the key. I mean, that was a big lesson learned, that it's outside of collaboration is also co-creation.
Yes. Fantastic. A couple of questions in the chat for you. Have you converted the Medicaid manual to electronic formats?
No, we haven't. But we have another portal where our business is keying in all the required CRD specifications, like what coverage instructions, what are the prior authorization rules, what are the documents, and any external references. As a part of our CRD response cards back, we have a portal where our business team is actively working on filling in the required information. So they are reading the policy manuals. The work is split across multiple offices, and they are deciphering the policy manuals into brief and accurate information that will be helpful to the providers.
Fantastic. Another question for the DTR workflow. Are you looking at doing a simple generic prior authorization questionnaire or a policy-based adaptive questionnaire?
It's a simple questionnaire that we find on the websites today, on the Medicaid website, on the Utah Medicaid website today, and we are going the route of upload, download of attachments rather than adaptive questionnaire for this go live. And adaptive is possible in the near future.
Excellent. Next question I have for you guys, external communication with partners, so just outreach. Is there education being developed to inform patients and partners of CMS-0057? Joellen, I'll ask you, Malati, and then Craig.
Simply yes. That work is very much in flight to kind of all of the external stakeholders. And, I'm listening to the wisdom of my co-panelists here, and also realizing there's an enormous amount of communication that's required internally to move this work forward as well. And so certainly using change readiness tools to touch work and move conversations forward for concepts that may be new to some is definitely part of our playbook.
Excellent. Craig, how are you guys doing in terms of communication and outreach regarding informing and educating the folks within your state and region about the new rule?
Yeah, so we're doing kind of less and less of the direct communication. We're very much kind of an intermediary in general. But something that I found very optimistic is that kind of a lot of times we tend to triangulate people that kind of are talking about other things, but that this will come up at. So, it's pretty frequent that at one of our committee meetings or board meetings or kind of different places in the state, this gets added to the agenda. And that's a good way to reinforce and get into the details. So it's not just kind of the fact that it has to get done, but who, how, why, and what the timelines are.
And Mala.
Our business teams are aligning communications with the CMS's best practices for provider and patient educational resources. And we are communicating this via our MIPS, and we'll be posting it on the members' Medicaid member website, the interoperability website, and our PRISM provider portal as well.
Excellent. There was a question from Peter in the chat. I know Joe Ellen mentioned the Washington group. Malatha, you mentioned the group in Utah. Does anyone, do either of you or anyone in the audience know of state-specific work groups? Is there a list of them where folks can kind of join and be a part of this collaborative nature? Are you familiar with anything else from the other states around you?
Yeah, I'm just familiar with the point of care partners work.
Okay, well, it's time for someone to put a directory together with a list of these states and the state work groups, huh? Let's get that doing. Let's get that going. Technical readiness, and I'll really lean on Malathi for this one. What has been some of the biggest technical hurdles, whether it's infrastructure testing, standard alignment? What are some of the roadblocks you're running into? You have a lot of success, but I'm sure there are times where you've kind of hit a brick wall or you've slowed down a little bit. And how are you guys addressing them in Utah?
Yeah, actually, you've got almost all of the hurdles identified here. Um, yeah, each one of them is a hurdle, but I would say standards alignment was one of our biggest hurdles in the sense the IGs are constantly getting updated. Um, now we are looking at US Core 6 beginning 2026. It's been a bit of a challenge to stay on top of those changes and ensure that they are being incorporated. And IGs are complex by itself, right? Um, we have an informaticist who is working full time and staying on top of these changes with our implementation guides. And then we use all our collaborative forums like Connectathons, and we are part of the community um, conversations that happen with burden reduction and PDEX community groups. We use our Zulip chats very effectively, and I think that collaborative connectathons and those are the ones that are helping us identify and resolve those subtle variances.
Excellent. Let's focus on data quality and exchange, something that all three of you are well knowledgeable of. How are you ensuring that the data being exchanged is accurate, complete, and usable for downstream decision making? Not you specifically, but how are your organizations addressing making sure that what's going in is good, so what's coming out is even better?
Yep, that's a very critical question, right? So when we look at peer-to-peer API, we are looking at profile-based validations to be built in to the into our API thing, and uh, apart from the usual spot checkings that the business will be doing against our PRISM portals, every other forum to make sure that the data that we are sending is accurate. We have our automated testing, Fire Validator, Inferno, all of those being used. The PA metrics, if it's prior authorization, those metrics will kind of show if we are sharing, if we are doing it right. Um, I think that is when we go live, right? All of these will really be seen. And until then, like we are just using the collaborative test and learn cycles to identify where data quality issues are most likely to occur, and then figuring out how best to address them.
Excellent. Joe Ellen.
Yeah, I really rely on my data and IT counterparts for a lot of the data integrity and reliability and quality. Um, Fortunately, right now we're in the process of a new 5-year strategic plan for data. And so that has been part of this work. At a granular level, operationally, where I sit, certainly we're working on policy inventory and management, and how that feeds up into a bit of system interaction. And hopefully we can get to digitizing those provider manuals, as we heard earlier today, the importance of that.
Excellent. And Craig, data is, a part, really, what CRISP and HIEs are really all about, movement of that data. So how are you guys, from your perspective, helping those in the state and region in terms of data quality?
Yeah, and it's an uphill battle, right, or a constant battle. So I think there's a couple ways we think about it. The first is just making sure that we have the right controls and processes to pull data in, deduplicate it, store it, do the right kind of MDM linkages, and get it back out in a way that's trustworthy. And so that's kind of constant monitoring, constant feed checks. Most HIEs can't live off a single standard, right? We're taking documents and feeds kind of however we can get them. And so hopefully, kind of any HIE, certainly CRISP Shared Services, spends a lot of time making sure that we can normalize and output consistently and accurately. I think two really important points, though. One is transparency. If we're doing those things and aggregating data, having the guides, the monitoring reports, just shining light on how things are transformed and the logic we're using to kind of append codes or different things becomes really, really critical. I think also, as we think about usability, we're exploring things with, for example, like NCQA, because there's likely, trusted partners may use data sets because they have confidence through kind of interactions and history. But something like a validation program is kind of the easiest way to provide a universal seal of approval. And so I'm optimistic that NCQA is starting to innovate along these lines and can really help to make sure that an HIE, a data aggregator, that's not just pushing kind of CCDAs from one place to another in the same exact format, but it's actually kind of making data more usable by upcoding it, combining it, and sending it, is then also trustworthy because it has the seal of approval and these constant checks. So we're looking at third parties because I know I can say it's good data, but obviously we want folks to have proof, not just trust us blindly.
Excellent. The three of you have very unique perspectives. Joe Ellen coming from the operational side, Malathi more on the technical side, and then Craig as an HIE, kind of almost, straddling a whole lot of different entities. January 2024, the rule comes out. From your perspective, everything that you've done and learned since then, what are the most promising benefits of 0057 for patients, providers, and state Medicaid programs once it's fully implemented? Who knows when that will be, but when it is, what do you view from your states and from your areas as like, this is what it's supposed to be? Like, what are the pure benefits that will help that multi-stakeholder arrangement? Oh, I'm sorry. Craig, go ahead first.
Yeah, and the first person is the easiest answer, right? Maybe I'll just highlight the efficiency. Having like one clear set of guidelines and expectations and results, I think is going to speed up kind of obviously the daily and minute by minute transactions. It'll also speed up kind of new entrants into the markets, new EHR conversions. I mean, standards are beneficial for lots of reasons, but I'm really looking forward to the consistency and the efficiency that will come from kind of everyone doing it the same way and in a very modern way.
Excellent. Malathi.
Yeah, the API program will allow full transparency and collaboration of the PA process. Uh, Transparency allows members and providers to take better control of the review process, timeline, and communication directly related to the care provided. It will assist Medicaid in improved collaboration of care between various programs and eligibility. And I think this increased transparency and collaboration is what will give us the opportunity to collect additional feedback in the future for the overall improved processes and improved Medicare member care.
And Joellen.
Yeah, I really appreciate a couple themes that I've heard just during this panel discussion about outcomes versus compliance and usability versus compliance. That's really important. We all know that this work is really administratively burdened to the teams that touch it. One of the other teams that I supervise is a workforce team, just trying to make sure that there's healthcare providers in Washington State to provide care to patients. And there is an enormous level of burnout in healthcare. And so simply put, I think this work will have a really meaningful impact for the teams that take care of patients, and we're all patients. At the agency level, I think obviously we anticipate faster throughput of care delivery, accurate clinical decision support, transparency, and the ability to track and analyze performance over time with the potential to identify any disparities in service access. So again, speaking to those standards about how data is formatted and transmitted, it can be game changing.
Definitely, and I want to follow up with you. You mentioned one item, and this is my next question was going to talk about risks. What are some of the greatest risks? You talked about resource constraints, burden, I'll mention stakeholder readiness, adoption. From an operational perspective, we already addressed some of the technical hurdles we might run into, but what are some of the operational from the business side? What are some of the risks that you might run into to Washington State that perhaps other states have to kind of consider?
Yeah. For us, I think our biggest hurdle and risk is funding. We're in a constrained budget environment right now. And so funding for resources, including FTE, is very tight. That lends itself to manual processes. We have aging infrastructure, and so that is certainly an opportunity. At a really granular level, risks include staff turnover and loss of knowledge. This is really complex work. So when we lose a key stakeholder, that slows us down.
Malini, you talked about the technical hurdles that you had, but what are from the business perspective? What are you at Utah thinking about in terms of the greatest risks you might run into?
I think stakeholder readiness is a major risk. The success of this rule really depends on not just a single organization, right? It's the entire healthcare ecosystem, and so there are interoperability gaps. So I think bridging everyone and getting everyone on the same page around the same time is probably the biggest risk. And we also have with standards like FHIR, there could be a problem in some inconsistent implementation. So, different vendors and organizations may interpret the same standard in slightly different ways, which could create subtle but critical compatibility issues as well. So, right, that may lead to some friction at the time of exchange when it's not being exchanged in the way that's immediately usable for downstream decision making. And that was one of the early ones that I found that I earlier spoke about was the DTR, where we were not ready for adaptive and we had to go for upload and download of attachments. DTR allows for it, but when we did the testing with a QHIN, the QHIN did not have that programmed into their system at that moment. So we was just that's one of the lessons learned, right? That in the future when we go live, if we have to interact with a provider who is probably ready for an adaptive or a CQL kind of questionnaire, but not ready for an upload or download, they may run into issues of exchanging their documents. So I think the stakeholder readiness and then compatibility are probably the biggest risk. And our mitigation strategy has always been to lean heavily on this collaborative testing and treat each failure as opportunity for co-creation.
Excellent. Craig, what stakeholder readiness, manpower, do you agree, like looking at it kind of 30,000 feet, are those some of the greatest risks you see in terms of overall implementation of 0057?
Yeah, like any huge project like this, it's certainly going to have to divert resources, time, and attention away from other things. And so certainly then that has all the complexity around, that Joanne and Malati also said, workforce and the complexity. I think actually the kind of the other side of the coin of that risk is that if we don't get the usability, if we're not going to drive efficiency and better processes once we're all live and moving forward, then it would be a shame. It would be a shame to kind of waste the resources to meet the compliance mandates, but not actually see any of the benefits that I think are intended. So I'm really hopeful, and it's great to be on a panel where folks are talking about not just technical requirements, but also what does it mean when you're doing outreach to different stakeholders, and how are they coming to the table, and what's the right way to move this together through change management processes. Because I think if we don't do that, then even if we meet the letter of the law, we still will have wasted lots of time and resources, perhaps, by not having more efficient workflows.
Excellent. And folks, once again, I'm getting close to the end of this panel. If you have any questions, please enter them in the chat. Looking at the future, beyond simply just the rule of law, looking beyond it, looking at beyond compliance, how do each of you see 0057 creating a foundation for broader innovation and interoperability, prior authorization, value-based care? What does the future hold? Beyond just simply let's get it done 2026, 2027, what are we looking at? What's the potential out there in terms of creating this broader foundation of innovation? We'll go Craig, Joellen, and then we'll close with Malati.
Wonderful. And thanks again. This has been a really good afternoon, a good discussion. So I think one of the things that we see in the HIE world is that you have to build trust locally and then expand use cases and usability from there. And some of the groups that are hardest to build trust across, of course, are payers and providers. And that's certainly not something that probably can or should change overnight. But I do think kind of once we keep driving transparency and accuracy and timeliness of this data, my hope is and my assumption is that payers and providers are going to start to see all the opportunities when it comes to better managing populations or being more confident when taking on risk-bearing contracts or talking through the appropriate kind of value of different populations when it comes to risk-bearing contracts. And so I think it's going to open the door to the much more complicated, but also probably more exciting conversations about care delivery. And this is the right way. It's already data that's interacting and already kind of handshakes that have to happen. And I think they're really going to pave the way for much bigger discussions, because hopefully the data and the trust and the transparency won't be the thing stopping us anymore.
Yeah, what he said. Thanks, Craig. That was perfect. Really, yeah. I just see this this work really, providing that integration of clinical and administrative data. It will allow teams to uncover actionable next steps to better take care of patients. And I think managing populations is spot on. And so, yeah, the elimination of the current silos that we have could be powerful.
Excellent.
Yeah, Craig and Joellen really covered it all. Implementation of API allows for the foundation of this transparency. This increased transparency not only improves the available care to the member currently in Medicaid, but it also inspires increasing collaboration among the various payers, providers, and platforms. Increased collaboration will allow for better member outcomes, improved policies and processes, and potential uniformity of care amongst various payers.
Excellent. I would like to thank the three of you for being a part of this very informative, very unique, and varied and diverse panel. I love the information that you offered. And by the way, once again, as I mentioned, a deeper dive into the work at Washington State with the payer work group will be featured at our national conference, November 3rd through the 6th in Washington, D.C., and on Zoom. So you can learn more about the group that Joe Ellen's also working with. Craig, Joe Ellen, Malathi, thank you once again, and best of success in your implementation efforts.
Thank you.
Thank you.
Thank you.
I'd like to now pass it on to my executive director here at WEDI, Rob Tennant, to discuss next steps and resources for everyone in the audience.
Thank you, Michael. That was a great panel. I really appreciate the insights that each of the three were able to provide, and great comments in the chat, good questions, and appreciate the answers from our experts as well. I think we wanted to start with our good colleague, Mark Scrimshire from Onyx Health, who will talk a little about how he sees the solution playing out as we get a little bit closer to the January 1, 27 compliance date. So I'll turn it over to you, Mark.
Thanks for that. So let me, I think I'm just going to try and grab a screen share, if you'll allow me to. There we go. Let's pull this up. I actually want to make an appeal to folks that are listening, particularly from Medicaid, and if there are any MCOs out there that are listening to this. First, what we want to think about is how we can build on what is being implemented as a result of needing to comply with the CMS mandate. But we can go further. I thought it was really insightful to listen to the questions Michael posed around where do we go beyond compliance and what does that allow us the opportunity to do. I want to give you just a little bit of background so you know where I'm coming from. I am the author of the Da Vinci Payer Data Exchange that is named in the regulation. So that covers things like the expansion of the Patient Access API, the implementation of Provider Access API, a bulk API for providers, and the Payer-to-Payer API. I'm also part of the financial management work group at HL7 and involved in Fireball as well. So I'm coming at this from what can we do with the APIs that we put in place or putting in place as part of 0057, particularly around these bulk APIs. How can we use those to maybe improve the sharing of data? And so this particular one, in recent conferences I've been involved in, people have talked to me about how they can make it easier for data to be shared, particularly around Medicaid beneficiaries. And we do know that many agencies work in partnership with MCOs, and beneficiaries can end up being moved from one MCO to another, maybe because they end up changing where they're living and so get migrated to a new MCO. We also know in many cases it can be difficult to reach out and get hold of these beneficiaries. So one of the things I'm really asking here is whether there is value in, as part of the work we're doing around Da Vinci and Payer Data Exchange, to look at maybe implementing an expanded consent requirement when a Medicaid beneficiary is being enrolled, and maybe have that so that the state could ask the beneficiary, do you agree to sharing of data amongst the MCOs so that your data is where you need it to be? And therefore then when an MCO is now enrolling a member that's maybe transitioned from another MCO or from Medicaid itself, can they look up that consent and incorporate it and use the payer-to-payer exchange that is already needing to be implemented for other means? And therefore, the benefit may be that you're better equipped with data about the member and helping to see that they're getting the right care. So that very simply is, I really want to know if people are interested. So just to try and put that visually, some people prefer to see things sort of in pictures rather than words. So think about that enrollment process. Could you capture an expanded consent that allows this type of exchange? Could the MCOs basically do a query to the Medicaid agency? Maybe that's where the consent is retained, so that they can see whether a member that they are enrolling has that consent and can therefore compile it into the member match query that goes to the relevant other payer, and being able to then retrieve that data. We need to work through the details of exactly how this would work, but we're really using the building blocks that are already being put in place as part of payer data exchange and the CMS-0057 rule. So what are the next steps? And I am trying to keep this this brief for Rob. Next steps. If you are interested in this, if this resonates with you, please reach out to me. You've got my email. You'll see it again. Send me an email. You can include the subject line along the lines of expanded Medicaid consent. I will know what you mean. And we can then work through, how do we define use cases collaboratively? That was one of the things that's really come out of the discussion today. We really need to collaborate to solve these challenges that we face. We can provide resources to help develop the reference implementations and then test it at these connectathons or other test events. And then we can also incorporate that guidance into implementer support pages that we have on Confluence that is tied to the actual implementation guide. So we have a lot of the structure there to be able to accomplish this. What I'm asking is this something that resonates with you? Should we go and do this? And who's interested in participating? So with that, Rob, I will hand back to you. So I'd love to hear from folks to see if they are interested in that. And maybe this becomes a subject for a future webinar that we cover.
Appreciate that, Mark. And as a reminder, Mark, as one of the authors of the implementation guides, take advantage of that. If you have questions of a tactical nature, Mark is here to answer them. So we've got a few slides, and I'm going to be joined here by Michael Lanzer from Itility Health and Raj Gadavarthi from MCG Health. So I'm going to walk through a few slides, but I'm going to call on my colleagues here to give their perspectives as well. I will say, there's been a lot of discussion here today about implementation of this particular rule. This is not the first rule that the industry has had to implement. Certainly, one of the challenges that we faced over the last 15 plus years has been implementing version 4010 and 5010 of the X12 transactions, and of course the ICD-10 diagnostic code set. If we learn from those experiences, I think we can apply this. Very few started early. I think there's always the sense of maybe it'll just go away. We don't need to worry about it. But we implemented all of those. It took a while, but I think we were successful. The one thing that jumped out, and I think we'll talk about it here a little bit later, and that is testing. It was absolutely critical that providers, plans, vendors, clearinghouses, intermediaries test to make sure that when we get to the go live date, we've solved the expected problems. I think that's going to be critical. We're also keenly aware that providers are not as educated on the rule as perhaps they should be. So I think there's going to be an effort made, not just by WEDI, but others over the next year or so, to not just talk about what are the technical requirements of the rule, but also, and we alluded to it earlier, what are the benefits of this new technology? How can it improve provider workflow and enhance the patient experience? As well, are there opportunities to leverage the technology so health plans can gain efficiencies as well. So that's part of this. It's not just trying to implement a new rule, it's really a transformation in how the industry exchanges data. But at the same time, when you do introduce new technologies and new standards, there are going to inevitably be business workflow issues. And again, not just for state Medicaid agencies, but all of those involved in exchanging the data. And I think one of the reasons why we decided to hold this event is because, Medicaid agencies in particular are facing some significant resource challenges, and they still need education and guidance regarding this final rule. So we hope that this will be the beginning of a partnership with the state Medicaid agencies to bring more information to the folks that really need it. So next slide. So I want to just briefly mention a survey that we did last January. We got 243 responses. And Michael, if you go to the next slide, I'm going to read over this and then ask my panelists if they found anything in the survey that sort of jumped out at them, either something positive or perhaps something that would pose a challenge. One of the things we found was 43% of the payers had not yet started work on the final rule, and only 31% were 1/4 completed. In terms of the top payer challenges identified in the survey, developing a cohesive enterprise strategy for interoperability, digitizing prior authorization policies, which we spent a lot of time on today, and not surprising, sufficient funding. On the provider side, 52% said that they had not yet started work, and only 14% were 1/4 completed. What was interesting is there was some overlap in terms of the challenges, sufficient funding, again, determining a cohesive enterprise strategy for interoperability, and sorting out various networks and how they interplay, TEFCA, QHINs, HIEs, etc. So maybe Mark, I'll start with you. Anything in the survey results that jumped out at you?
No, there's a lot that we're seeing also being confirmed by simply the volume of RFPs that are coming out from primarily payers to at least start thinking about what their solution is. So that's one thing. There's a lot of, particularly I think the smaller and mid-market payers are really just gearing up to realizing it's not necessarily going to get delayed. I think the first half of this year, there was obviously questions about whether CMS was really going to follow through. Now we're clearly seeing they're doubling down. That goes to one of the second points about that enterprise strategy. I think many payers in implementing the original patient access API saw it as really just a compliance exercise. Now, it's very clear that CMS is committed to the use of FHIR. We're going to see expanding use across different areas, including things like quality. And so you really need to think about, have you got the right platform that is going to support all that as you go forward? And on the provider side, I think a lot of providers are probably depending on their EMR vendor to come up with the solution and be able to roll it out quickly. So no real surprises. It's unfortunately, it's the reality. People have tried to delay the inevitable.
Good point. Raj, thanks for joining us. And anything jump out from the survey for you?
Definitely. I think on the payer side, it's been a drag since the beginning of the year. But there is a good news. I mean, last few weeks, I'm seeing a lot of decisions coming from RFPs. I think what happened really was the delay is not just because they don't want to do it. It is largely because it turned out to be an enterprise level initiative, which requires many departments to come together, understand the impact, understand the dollar impact and all that stuff. So we have worked on RFPs on top of RFPs as they have understood the scope. So I think largely they're heading there. They know that they have to make decisions next 3 to 4 months if they have to meet the deadlines. It didn't surprise me when these stats, but I expect by Q1 we will see a little more uptick here.
Appreciate that. Michael, any thoughts in terms of things that jumped out at you from the survey?
Yes, I guess the first thought is that as of the results of the survey, I think that 31% 1 quarter completed is a really generous metric, self-reported. I think there's still a tremendous amount of lack of knowledge about what these standards require. And even some of those that we're seeing from RFPs are showing the lack of appreciation for what this requirement is. So I think we're going to continue to see an explosion of required customers requiring a solution over the next 6 months. And those, of course, that are going to start at the end of 6 months from now are going to find themselves in a real challenge to accomplish the task. The good news is that every implementation we do, for example, gets faster and easier. So I think those of us that are doing the work are getting better at doing it. So I think that's probably the biggest thing that jumps out here is how even as of the beginning of the year, there was a lot of self-reporting that they were well underway, and I think it's a bigger task than many organizations have identified as far as multiple vendors that they need to select. Specifically, we find companies we talk to that assume that their one vendor for one piece is the vendor for everything, and they haven't really dug in to what other vendors are they going to need. So,
no, great points. Next slide, if you don't mind, Michael. I think one of the or some of the key questions that jump out at me, and I'm not saying we've solved or answered these questions. A big issue that was brought up right at the beginning by CMS when they had their chart up was a number of the implementation guides are recommended, not required, and that brings in some uncertainty. There's also the question, because we know with 4010, 5010, even ICD-10, intermediaries played critical roles in making sure that the data was continuing to flow. So we're not sure exactly how intermediaries are going to play a role here. Is it going to be transactions driven through these to get ultimately to the payer, for example, and then back to the provider? And it was great to see CMS include the rule that made it into the unified agenda, which would include drugs. And I've put a link here, so when you get the slides, you'll be able to access that placeholder in the unified agenda. Just know that just because a rule is included in the unified agenda does not mean there's a guarantee that it will come out, and certainly not on the date that it is lasted for. And then a big issue was for me is how will commercial payers, those that are not required to comply with 0057F, how will they react to these APIs? We've heard a lot of discussion around that health plans are looking to have one system for prior authorization. It wouldn't make sense for them to have old ways for some plans and new ways for or products and APIs for some. So, but that's still a bit of a question mark. We're not sure, but some questions have been answered. And if we go to the next slide, I think part of the reason I believe that the numbers in our survey showed a lot of folks hadn't really started was this general uncertainty, in particular at the beginning of the year. We had a new administration. There was no guarantee that 0057 would move forward, but there have been some developments over the last few months. I think an important one was the announcement from HHS that a number of leading health plans, around 50, had signed a pledge to address prior authorization and support the FHIR APIs in real time. So that was a major, I think, boost to the industry. And then Chad brings it up in the chat. The fact is, what about the vendor side? They're not required under the CMS rule to support the APIs. That is done through the ASTP, the Assistant Secretary of Technology Policy / Office of the National Coordinator for Health IT. So they've created a certification program that supports providers in the EHR incentive program. So the fact that ASTP came out with a final rule, and what's called the HTI-4 rule, requiring certified EHRs to support these APIs. Again, a major step forward. And interestingly, the rule requires adherence to the implementation guides. So again, the hope is that that will translate into providers having the technology to be able to take advantage. So I'll stop there. And any thoughts? Maybe I'll start with you, Michael. Any thoughts on how the uncertainty has been reduced?
Yeah, I would echo what Raj had to say. The level of activity from a health plan outreach perspective has really reached a fever pitch. Everybody is moving quickly. Again, to refresh one of the things on the last slide, everybody that we talk to that is a commercial health plan that has business lines that are required to implement these capabilities is planning to use these capabilities for both their commercial and their government-related plans. So the announcement in June has been a really significant, had a significant impact. I think the other thing that was really dramatic impact was Dr. Oz's quote that the marketplace needs to implement these solutions effectively, and if we don't, the government will step in and do something we won't like. So I think that behooves us all to make this a win-win. All of the vendors that I know we're all working together, even if we have a little bit of competitive overlap. We're working very quickly to make sure that we can all talk to each other effectively and leverage these capabilities. So I'm just super bullish on where the market is going and the excitement about it within the payer community. Just very interested in seeing more movement on the state Medicaid health plans and stand ready to help in any way we can.
Appreciate that. Raj.
Yeah, I think on the first one, the pledge, when everything that happened, the news came out, I was thinking, is it really going to be, anything different than what you have seen last 2 years? I remember in the last 3 months, one customer said, hey, my management said, we need to prove something based on the pledges we made. The only way to get there is through the automation. There is no other way to show that what we pledged on reducing the prior auth burden. Even some organizations are making some other decisions, but I know organizations who are heavily leaning onto this implementation to show the progress. So that's a really good sign when I heard that. And then the certification is a big deal. Without that, this is not going to work out on both ends. I still have ways to go, but I see some momentum. Definitely uncertainty reduced. I think the only way we can count on these things are when people are using together in production. So,
yep, Excellent. Mark?
Yeah, that's a number of good points. I think the fact that there's a lot of the uncertainty has been dispelled is allowing people to move forwards quickly. I agree with Michael. We share clients and we are seeing them saying the benefits of implementing prior auth are so powerful. It's crazy for us not to implement across our entire member base. And you're seeing people like the Blue Cross Association saying the same thing. So they're moving all of their affiliates in that direction. You heard it on the call today. You mentioned the question about the recommended implementation guides, but I always say read the tea leaves. And you heard, I think it was David Koppel or Scott saying, strongly, strongly recommended. You read it. As an author, I am actually pleased that they didn't make the IGs required straight off the bat, because we are still learning, we are still evolving. And if they had planted that, that would be like a rock tying us down. You need to follow what is happening with the development of these IGs, and you can still influence how they come out, because we take the feedback as part of reconciliation when these standards go out to ballot. So it's really important that the industry gets engaged. The other point I would make, testing. We really have to think about testing, because how do we test for the happy path? We're all pretty good at testing the happy path, but we need to be coordinating across organizations, across vendors, across agencies, to make sure that we've got both happy path and unhappy path. Can I put in a prior auth for this fictitious member and it should pass? And that means you've got to have an EMR in a test that has information about a patient that is in the payer's test platform as well. We have to get our act together. And I saw a question in the chat about, are there going to be certifications? Yes, the industry is moving on that. And I see those as a good thing. But it's going to be more than just the APIs. The one thing we haven't really touched on, which maybe comes into the TEFCA and the network space, is thinking about how are we going to register the tens of thousands of providers, the approximately 1,000 payers out there that are going to have to interact over secure APIs. Adopting the technologies that are in FAST and TEFCA is that going to be absolutely critical, because we cannot register all of these endpoints by hand. It will take an absolutely enormous army to do that, and that is crazy. When agencies are saying we don't have the resources, you do not want to have to employ an army just to get people connected to your APIs. If we don't solve that, this is not going to work.
Yep, good points. Michael, we're going to move through the next few slides in a bit of a hurry and we've talked about our sub work group. I want to talk just briefly about some of the projects that we're considering developing and rolling out. And Mark, in particular, you just mentioned something critical. We've got all of these payers, all of these providers, these EHR vendors. They all need to come together and start to test. Connectathons are one thing, piloting is something else, but real world testing with data is going to be critical. So Michael, if you go to the next slide, go ahead to the next one. We'll skip ahead. So one of the things that we have been discussing is creating a testing directory. So this would essentially be sort of a matchmaking effort where we're not going to test ourselves. We're not going to pilot anything. We're simply going to list folks that are ready and interested in testing with their partners. So again, it would be voluntary, of course, And as well, if there are some experiences, whether they be good or bad, we want to hear about them, because the only way we're going to learn as an industry is for folks to begin to test and report what the results were. So look for that over the next couple of months. We're going to be working with our sub-work group on this to make sure we're collecting the right data, and then really push it out and encourage folks to come and say, hey, I'm ready to test the CRD. Who's with me? And so I think it's important. Mark? Yep.
Yeah, I was just going to say, you want to make sure that you are coordinating. Da Vinci has Trebuchet,
Yep.
which is obviously coordinating testing around a lot of these recommended IGs. And also FAST is spinning up a testing initiative as well. And all of these things really need to come together. And you do not need to be a member of Da Vinci to get involved in the Trebuchet testing. So what we do need to do is make sure, I think the role of creating that directory is only going to be helpful. You've got to be able to find out, where do I go to register and get a set of credentials so I can now do testing, and now what information do I need to share with the other party or receive from them in order to be able to put valid tests together. So I think there's a valid role to be played here. Just be careful about stepping on other initiatives, because it will end up distracting.
Yep, no, a good point, Mark. We've actually already talked with the Trebuchet folks, so they're well aware of what our plans are. Again, really, our goal at WEDI is to be sort of an to amplify the work that others are doing. So the one thing that we've asked of Trebuchet is to share their experiences. We would be happy to include them on podcasts and on webinars, because people need to hear from those that have gone through it. And so I think that's we're absolutely in alignment on that, Mark. So thanks for bringing that up. Next slide. We're also talking about developing industry guidance and best practices, exactly what WEDI did during the transition to 4010, 5010, and ICD-10. Again, things that are on the business side, perhaps not on the technical side. So again, building trust between providers and payers on the CRD and DTR, the timing of the responses. Are there I want to say easy, are there best practices when it comes to reporting these metrics, for example? And of course, planned consistency. So if a provider pings them via CRD, goes on their portal, sends, God forbid, a fax, and makes a phone call, are they going to get the same answer back on whether or not a service requires a PA? Next slide. Again, we've talked about this, the role of intermediaries. Also, app security. We have a privacy and security work group that is going to be looking at this. In particular, things like, the patient access API. If the patient's API is, we sell your healthdata.com, there could be some concern. So we want to have some best practices there, and also developing timelines and milestones that organizations may want to adhere to make sure they're going to be ready for that compliance date. And next slide. And again, we're talking about collaborations with the Da Vinci folks, with Medicaid agencies, with provider and payer associations, with the Cooperative Exchange, which is the trade association for clearing houses, Sequoia and Civitas on these intermediaries, with EHRs, and of course with our good partners in the federal government. And next slide. So anything that folks want to put in the chat, or if they want to come off mute quickly to raise, anything that you think that we should be including in our list of resources and work products. So please feel free to put it in the chat. You can also reach out to WEDI via email. And so with that, I think we'll move to the next slide. We're just about at time. A big thank you to our event sponsor, Itility Health. They are a wonderful partner with WEDI, and as you can tell, they are really wonderful experts on this very important CMS rule. So thanks so much to them. Next slide. The conversation continues not just on this CMS final rule, but also on a host of other data interchange issues. This is a hybrid event. We encourage folks to come join us live in DC at American University, but we also offer a virtual option for those that can't travel. That'll be November 3rd through the 6th, and we look forward to seeing you there. And if that's the last slide, Michael.
Yes,
With
it is.
that, okay, I just want to take last minute and thank our speakers. Fantastic presentations. We hope you found some value from the program, and reach out to WEDI with any questions. And a big thanks to our own Michael McNutt for making things run so smoothly. And thank you all for attending. And we look forward to seeing you at future WEDI events. Thanks so much.